and put your questions into chat, and then we will get to those very shortly. We're not going to do medical questions here today. This is really more information about when and where to go when you are not feeling well. So our speakers today are Elais Ponton, who is the Chief Nursing Office of Nursing Officer of Nurses with Heart here in Santa Fe. And we've worked with Elais for 7 years now with fall prevention, and we do appreciate your hosting this event as well. Also with us today is Dr. Lindsay Ballard, who is a board certified emergency medicine physician in Portland, Oregon. She's also a board certified hyperbaric wound care physician in Portland as well. So I'd like to introduce Dr. Ballard, and full disclosure, she is my daughter. So if she will unmute, and she will tell you a little bit about what she does and what her daily routine might consist of.
Sure. Good afternoon, everybody. I'm Lindsay Ballard, or Dr. Ballard. So day to day, I typically work in the emergency department. I work in a small emergency department here in Oregon. We have about 25 beds, and usually we have 2 doctors on at one time. So between me and the other doctor, we see everybody that comes through the door, in all honesty. So it can be something pretty small. It can be colds. It can be all the way up to heart attacks or other types of resuscitations and things like that. So lots of coordination of care, and kind of what we're going to talk about my day-to-day effectively. I'm also a hyperbaric and wound care physician, which is sort of an odd subspecialty. So I take care of chronic wounds, which you might be familiar with, things like lymphedema, diabetic foot ulcers, venous ulcers. If you ever see people with those funky wraps on their legs, that's my other day job. And then for hyperbarics, we treat wounds, and then lots of post-radiation symptoms, actually, from people that have had cancer in the past that have undergone radiation therapy. So happy to answer any questions about that at the end.
I understand.
And so, Elais, would you tell us what you're doing and what's going on with you?
Sure. So my name is Elais Ponton. I'm the Chief Nursing Officer of Nurses with a Heart. And yeah, I'm sorry, we're just figuring out some, I think this coming out of here. Just give me 1 second. Yeah. Okay. Oh, no, we're still, okay. So what I'm going to do, I'm going to run into the other room. That will solve this. All right. So as you just got a very brief tour of our office, so my name is Elais Ponton. I am the Chief Nursing Officer of Nurses with Heart Home Care. I originally started off working on a high acuity unit for seniors. I was also had some experience on a surgical ward, and from there became very interested in wound care. So that's where Dr. Ballard and I kind of start to intersect. And my interest in wound care led me to home health. And so since then, I've done a lot of wound care in the home health care setting. I've also worked in the hospice scope of home care, and have owned and operated, along with Carolyn Moore, our CEO, Nurses with Heart Home Care since 2010 in Santa Fe, New Mexico. So we provide both medical and non-medical care because we're licensed by the Department of Health. So we do everything from wound care and medication management and case management to bathing and grooming and everything that helps keep people comfortable in their homes. So I'm currently working on my doctorate. So that's keeping me busy, and as well as presenting with villages. So we love our community resources, and Villages is just a wonderful resource in Santa Fe. So thank you for having us.
So what we're going to talk about now is where you should go and what to expect. And I'm going to give you an overview, and then we'll turn it over to Lindsay and Elais to discuss the different aspects from their side of it, from the medical side of it. So if you fall, you hit your head, you wake up in the middle of the night with intense abdominal pain, you have a high fever, your partner has a high fever. When these situations occur, we really suddenly face uncertainty as to where to go for care. The answer is only sometimes straightforward. Knowing the difference between an urgent care center and a hospital emergency room can make a big difference if you have a medical emergency. There are distinct differences between hospital emergency departments and urgent care centers, including associated costs, interventions provided, and the level of care provided at each facility. So just does, there we go. I'm going to mute myself and then let me change.
So Lindsay Ann is introducing you.
So do you want me to start? Sorry, I can't hear Anne when she's muted. So if she said something.
Oh yeah, she
Okay,
was just
great.
introducing you, and yeah, and
Oh,
so
perfect.
yeah.
Great. Okay, yeah, fantastic. So, I mean, effectively in the emergency department, we can really see anything, right? So, kind of in unclear circumstances, we are capable of seeing anything kind of from very minimal to very, very high acuity. I think like Anne was saying, generally, you will have licensed physicians there, which makes sense. Typically, they are at this point, day and age, only emergency medicine trained, but historically, they're not always emergency medicine trained. So they may have been trained in other fields, such as internal medicine, which is the kind of doctor that you might see in the outpatient scenario. You might have an internal medicine doctor as your primary care doctor. Sometimes the internal medicine doctors also work in the hospital. And then family medicine is another common specialty where they get a fairly wide breadth of exposures. They may be staffing the emergency department as well. I think in urban centers, you're going to see only emergency medicine doctors, which is a specific specialty that goes through a specific training circumstance, just kind of like, you know, you go to medical school, then you go to a specific residency training, which is that post-medical school training where you're a doctor, but under the supervision of other doctors. And that's really geared towards like this day and age of emergency medicine, where you know a little bit about everything, but the emergency medicine doctors are not surgeons, for example. So while there might be some surgeons around, they won't be also performing your surgery. The emergency department has a lot of other people staffed there, and you can see all kinds of interesting things. When I did poll some of the other emergency medicine physicians on what they kind of would recommend in terms of when you're kind of thinking about sorting between emergency department or urgent care, you know, typically something that you're going to go to urgent care for, but not always, would be something that you might be able to wait a little bit for. For example, something that you might be able to see your primary care doctor, maybe if you can sneak in with them if they're not super busy, which doesn't really seem to be the case most of the time these days, unfortunately. But it might be something that you could generally see someone within a couple of hours, you know, like maybe 12 hours, or maybe even wait until the next day. There's a list here that we can go through. The most common things that I see people sent over from urgent care to my department specifically for are head traumas, especially in someone over the age of 65, or if you're taking any blood thinner medications, that would count as, you know, warfarin, Xarelto, rivaroxaban, apixaban, Eliquis. You may know that a lot of those are the same medications, but some people only know them by some names. Aspirin also counts as a blood thinner if you're over 65 and you hit your head. Chest pain will always pretty much come to us as well, always be referred over to the emergency department. Most abdominal pain as well, unfortunately, because it's kind of hard to parse out where that's coming from. And then I think those are the most common ones that I see that like maybe initially went to urgent care that are actually kind of then siphoned off and sent over to us after that.
And that's what, so, and coming from the home care side, when we tell people to call 911 is exactly what Dr. Ballard said. Anytime anyone falls and hits their head, for us, that is a 911 call. If there's uncontrolled bleeding. Also, if someone becomes suddenly confused, so say their normal cognition is walking, talking normally and appropriately, and all of a sudden they're saying things that are inappropriate or they're not responding properly, that is also a call to 911 immediately. And of course, anytime that we have allergic reactions that can't be managed in the home, like say someone's having to use like an EpiPen because it's potentially anaphylactic, that is also a 911 call for us, especially in our senior population. And so we talk a lot about, especially coming from a home care setting, when you call 911, what should you bring with you to the hospital? And so from our side, when we're leaving people's homes, we want to make sure that you're bringing important health information with you, which includes a list of medications and supplements. I'm sure that Dr. Ballard has the same experiences that I do when people tell me that they take a yellow pill with red letters on it 3 days a week and a blue pill at night 2 days a week. And so having an actual list of medications with the name of the medication, the dose, and how often you take it is really important. Supplements are also really important to include on that list as well. So you can either take a photo or type up a little list. I have like a little cue card that's in my wallet that I just have everything written down on that just lives in my wallet. It just makes it easy that way. Because even I can't remember the names of things. A list of medical conditions, if you can possibly list that as well, along with the name of your doctor and pharmacy. If they will be prescribing something at the hospital, it's really important to know at least the street that your pharmacy is on. The name of it is also very helpful. And if you can write down the phone number, because that will make things easier for when you're discharged and you need to pick up your prescriptions after. You of course want to make sure you have your health insurance and vaccination cards with you because they will be requiring that, your health insurance information. And then something that we always tell people is you have your phone, you need to bring your charger. Dr. Ballard is going to talk more about how the process works when you get to the emergency room, but you could be there for a while and your phone is not going to last that long. So having your charger really is key. And of course, patience. Always bring your patience. But Dr. Ballard, are there any other things that you could see that would be helpful for people to bring with them to the hospital?
No, I think that's fantastic. I love the list of medications specifically. And I've seen the same where people have a little sheet that they keep in their wallet or purse or something like that. And sometimes they'll just put kind of like, I take this one for this thing and I take that one for that thing, and kind of it gives you a better idea of like why we might change some things if you already know why you take some things. But just a straight list is fine. If you say it's in the chart, it may or may not be in the chart. It's true, it might be in the chart, and that's one way to go about it, but it might not be. So that's a little bit more difficult. Some of the systems don't link up as nicely as we would like them to, unfortunately.
You reminded me of one thing that I frequently hear from people is that I've sent my advanced care plan to the hospital, or they have my DNR. I'm sure that you've done that and they might have it, but they might not be able to find it. So that's always also something that's good to bring with you just to ease the process.
Yeah, and I've seen a lot of people that will come if they come from a care facility, but not necessarily from home, have a packet like that, and the DNR or the Pulse is with that packet. But like you said, if you have some type of strong preference or there's something going on, or especially in the sense if it's a truly emergent issue, sometimes having that paperwork right away is much more helpful than having me decide at the last minute what we're going to do in terms of not knowing you and not knowing what you would want.
Yeah. So when you get to the emergency room, I think that something that people need to be aware of is that no one is ever turned away. I know that there are a lot of rumors out there that there's stuff on the internet, but people are not turned away from the emergency room. You might be rerouted to another hospital. That is a possibility. I know in Santa Fe that happens quite frequently. People will be rerouted from Presbyterian to St. Vincent's because Presbyterian might not have the specialists or the supplies that they need. So they might be sent to Christus. And additionally, oftentimes people, whether it's Presbyterian or Christus, are medevaced to Albuquerque for conditions that need further management because Albuquerque has a higher level trauma center there. So it's important to keep in mind that you can always be seen in the emergency room, but that might not be the hospital that you stay at.
Sure, and that's even true. You know, I live in an urban area in Portland, and we have 3 very large hospital systems, 4 actually, if you count another one that's like kind of a closed system. And similarly, not every hospital has everything that you need. So if there's something that is obvious to, you know, if you're coming by ambulance, if there's something that's obvious that you're going to need to the EMTs or the paramedics, they may bypass what you would normally prefer for a specific scenario. Like the thing I can think about for my hospital, for example, is that we don't have what's called a catheterization lab. So if it looks like you're having a heart attack on your EKG, they will go past us in the ambulance. Now, if you arrive and walk in, we will get you to the right place within the right time frame. But if you're in an ambulance and you're like, I always go to this place and I want to go to this place, they may bypass our hospital because we just don't have what you need. So I agree. But there is the rule is called EMTALA. It's actually a national law that you have to be screened medically. So you can't be turned away, although wait times sometimes make it seem like you're being turned away. Unfortunately, we have the same problems as everyone else with wait times. Oh yeah, so going into the wait times. So what to expect at the emergency department. So if you walk in, you'll come in through the front doors and there's a registration scenario. And that's the part where you just kind of walk up to a little window, sort of looks like the bank. And they'll take your information and kind of a chief complaint, like, what are you here for? Are you here for shortness of breath, chest pain, those kinds of things? Often there will be a little sign at the window that says, if you're having any of these things, please notify us immediately. So if you're not sure if this is like a true emergency, they sometimes will have a little plaque, and usually that involves chest pain or shortness of breath, or, you know, if like a bone is sticking out of you, it's something like that. The next step will be to see one of our triage nurses. So you'll go kind of like into the waiting room, and then you'll be called up to one of the rooms that kind of opens to the waiting room. And the triage nurse will get kind of more in-depth history and also get some vital signs. And then the triage nurse will kind of help us make a decision on what kind of acuity level you fall into. And acuity is kind of like a word that they just use in the emergency department to define kind of the level of danger, and then also the level of like resources that you might need in our department, because a lot of it is about resource allocation. After that, you probably will wait, unfortunately. So that's where the patience part comes in. Occasionally, the triage will go right back. It kind of depends on what's going on. It also depends on what's already going on in the emergency department. And unfortunately, these days, it also depends on what's going on in the hospital. So we'll get to that as well. At some point, you will get roomed, but maybe wait a little bit more, because sometimes it's a technician instead of a nurse that will come get you, you know, bring you back to a room, make sure you get settled, tell you where things are, get you a blanket, that kind of thing. Often people wonder at this point if they can have anything to eat or drink. And the answer is always going to be no until you see the doctor, or maybe I call the APP, which is the either nurse practitioner or physician's assistant that might be seeing you. After you get roomed and maybe wait a little bit more, then you'll see at least a nurse who will do the same thing, kind of come in and check in. Sometimes I'm able to sneak in at that same time with the nurse so we can get the whole story together, which is a little bit nicer, I think, for the patient. Not always possible, so I apologize for everyone in advance that you may be repeating your story a number of times that day. After that, you know, when I pop in, that's when we kind of start to get things moving. So we get to decide what's really going on, what we think's going on, what we think could go on. And that's where I'll order kind of like our we need some labs, if we need imaging of some sorts, you know, like an X-ray or a CT scan, and get you hopefully a little bit more comfortable if you are in pain. So like pain medications, nausea medications, fluids, the nurse will kind of get all that organized for us. From that point is often about at least a 3-hour wait again. And that's because of just how the emergency department works. So I know at that point, I see a lot of people who have seen lots of people go ahead of them, which is not that fun to see. And then also wondering kind of like, well, I've already been here for this amount of time. How much longer do I really have? And that's why I say kind of a minimum of 3 hours. That's sort of like a bench point for kind of like most normal kind of middle of the road urgent type of things. So yeah, so staffing, I don't know if Elais, if you want to pop in at any time, let me know. So at my department, we actually only staff with MDs and DOs, who are people that have gone to medical school and then residency, and we only use emergency medicine trained people. But like I said, sometimes you'll see other types of doctors, which is fine. So internal medicine, family medicine, that's a little more common in rural areas, but they also have a good breadth of experience. And many of those people have worked a long time in the field, like from before emergency medicine was a specialty, which started in 1979. So there are also other types of, I said APPs, which is kind of like a lump sum for called advanced practice providers. So that could be a physician's assistant or a nurse practitioner. It depends on where you go and what you'll see, kind of maybe the same, maybe you've seen some of them in your primary care office as well. In some departments, they have acuity, I call them acuity expectations, where the PAs or the NPs will only see certain levels of acuity, which is kind of the mid to lower range. Whereas if it's a resuscitation event, which is like what you might see, you know, on TV, like in the ER on TV or something like that, that would be the doctor's kind of component. But you might see someone like that if you have abdominal pain or things like that. And then we obviously need nurses for all patients, and that seems like an easy thing to get, but it's not. You know, my mom was just asking me this morning how things were going, and unfortunately there's actually a really big nursing shortage out there right now that affects all types of hospital specialties. Emergency medicine is included in that. So we have had to shut down some of our beds occasionally because we don't have enough nurses. And it's not because we don't have enough doctors, and it's not because we don't have a lab, or you know, it's not because the hospital doesn't have the things that it needs, but we also need nurses. So sometimes that will also slow things down. Like you might see empty beds, and that is because we don't have enough nurses. And that can be also from the inpatient hospital side as well. So sometimes if there are not enough nurses in the hospital, despite our emergency medicine department running at capacity, so say we are fully staffed, we don't have rooms to send patients to. So that can kind of slow us down as well. And then we have technicians as well who do all kinds of other things for us. So we have a lot of people, there are a lot of moving parts. We have, you know, like a little anthill where everyone's doing all their different things. And then we talked briefly about acuity before. This is sort of, I mean, I think as a patient doesn't really matter, but it will show you a little bit more about why you might be waiting longer. And I know it's not very fun to be passed over because the emergency department doesn't run on a scheduled time like the primary care doctor's office. But it's a number that's assigned by that triage nurse that would see you kind of up front. It is based on a lot of different things, and it is a little bit subjective, but pretty much everyone in the emergency department uses the same scale at this point. So it's fairly objective across people that have done it for a long time. So it depends on what your complaint is. So like what's going on, you know, you're having chest pain, you're having abdominal pain, you think you broke your ankle, that kind of thing. Age, vital signs, and then the expected resources is actually, I think, the part that is harder to understand as a patient than, you know, as coming from like a departmental type standpoint, because that's kind of like in terms of running our department, not necessarily like how much pain you're in or that kind of thing. So a 1 would be someone who is probably actively dying, and that needs someone, they will usually be coming by ambulance at that point. So we don't see a lot of 1s, which is good for everybody. A 2 is fairly emergent. So the most common 2 I think that I see would be someone that has a really fast heart rate. Some of you guys might be familiar with something called atrial fibrillation, which is an abnormal heart rate, but sometimes it can go really fast. So someone with a really fast heart rate that might be experiencing shortness of breath or chest pain or fainting. That's probably the most common two that I see. And those will also be someone that's coming probably pretty much straight back because they need something going on right now, like pretty much now. A 3 is more in the urgent category, so that they call that within through like 6 hours or so. So a lot of 3s will be something like abdominal pain. So you'll probably need some imaging if you're having abdominal pain. If you're over the age of like 10, something like that, and then some labs. And so that's kind of where the expected resources part comes in. And then 4s and 5s are lower acuity on that sense, but will not be turned away. They will just get passed over and over again, unfortunately, for all of these upper levels. And some of that can be like sprains, that kind of thing is, I think, probably the most common 4 would be like a cold type symptom or a sprain, ear pain. Not very common in the older community, but sometimes, mostly kids, that kind of thing.
And so, Dr. Ballard, if and before Anne, you switch to the next slide, maybe we could walk through just kind of an example scenario, just so that people would know what to expect. And so, if we talk about from like coming from a community setting, so say I'm with someone who's having extreme chest pain. Maybe they have a history of high blood pressure, of hypertension. My recommendation is always go to the hospital in that situation. We want to be as safe and as cautious as possible. So we get them to the hospital and we go up to the front desk, or this is in a situation where obviously we haven't called 911. Can you walk us through, they're having chest pain and they have a history of hypertension, and let's say that they do find an occlusion, how you would rank them in acuity and how they would be moved through the emergency room and then into the hospital?
Sure. Yeah, so chest pain is actually one of those things that they have on the little plaque next to the registration that says, please let us know immediately if you are having chest pain right now, because there are actually certain standards that are required, not like part of that EMTALA, turning away type law, but just kind of that we expect. So one would be that active chest pain, and if you have any history of other problems that are related to chest pain, something like high blood pressure, high cholesterol, if you've had already interventions on your heart before, if you've had a cabbage or some type of triple bypass, those kinds of things, would probably actually put you into the 2 category. So what will happen is one of the technicians would probably actually come to triage and get an EKG within a couple minutes. Usually 10 minutes is the cutoff. And that EKG will actually be seen by a doctor within 10 minutes. So the doctor might be doing something else entirely, and they will find someone doing something else and interrupt them to give them that EKG within 10 minutes. If the EKG looks very suspicious, the patient would then be brought back totally emergently. And actually from my facility, we would actually start to arrange transport to a facility that has a catheterization lab. So sometimes there are some things that you can see on the EKG itself that are suspicious for an occlusion, so a heart attack. And we would start medications right away. I get on the phone with the cardiologist after briefly talking to the patient, kind of just to get as much information as I can immediately. We order our labs there, and that's anywhere they would start an IV, and get medications on board, and we would get them transferred out. Now, if you have it's a big hospital, say, and they have all the things, they would do all those same things. They would get your EKG within 10 minutes. A doctor will see it with the EKG specifically within 10 minutes. If it looks suspicious, you will be brought back immediately, and all of these things will be kind of clicked into place. It's sort of what they call it the door to balloon time, which is the time you arrived at the door to the time that you go into the catheterization lab should be under 90 minutes. So it's a pretty quick process for this particular pathway of chest pain if it looks like there is actually like a big heart attack coming on. Now, sometimes if you have really bad chest pain, the EKG, which is, where they put all the little electrodes on you, does not actually look very suspicious. And that can happen. Your EKG will still be seen by a doctor within 10 minutes. That's always the case for all EKGs. But if it does not look suspicious and you kind of fall into the 2-3 category, more on the 3 side, you may not come back immediately, but your labs will be drawn immediately, because there are certain lab specific labs that can also look for heart blockages. So heart attack as well, but not the same one, not as big, I guess you could say sometimes, as what you can see right on the EKG finding. And so if you don't look well, they'll still bring you back. Like if you look really pale and cool and clammy and sweaty, you'll still be coming back to see us no matter what your complaint is if you don't look so good. But either way, sometimes, you know, if it doesn't show that big finding on the EKG, you'll still be brought back and your labs will still be drawn. So you could still be having something going on. So we don't want anyone to go just because they got an EKG that looked okay. We'll bring you back and we'll kind of get those things moving. Now, one thing that I've seen that I don't know happens there as well is this fancy thing called My Chart, where you can see your labs sometimes before the doctor can. And that's an interesting finding because, for example, in this particular instance, if your chest pain started, you know, within an hour or so of when we draw that lab, you might have a normal lab, and that does not mean you're not having a heart attack. So it does not mean you're like, hey, I checked my chart, looks good, I feel fine, let's get out of here. Because that does happen sometimes. Obviously we call people to say that's not really how it goes, but so just be aware that, you know, some of those labs are very time sensitive and some of those things don't necessarily mean what you think they mean, even though they're in like a normal range or an abnormal range even sometimes. So I think in terms of chest pain, that one's pretty straightforward. So if it looks something very bad and you're having a big heart attack, we will get you into that cath lab within 90 minutes to go get an intervention where they try to, you know, kind of roto-rooter out the arteries there. Sometimes if we're not sure, we'll talk to you about staying. You know, I find have a lot of people who have a lot of risk factors for heart stuff, and their chest pain sounds pretty questionable. You know, like it hurts a lot, like when they're moving around, or you know, I always get the same shortness of breath with some nausea when I go up the stairs. Like that's concerning to me. And we might talk to you about staying in the hospital, not necessarily to get that catheterization where they are very invasive and they go in, but to get a stress test, which is a little bit different. So there are a couple different routes. And what I would do in that front is make sure you're on board with staying with us. And then I call the hospitalist doctor, one of those like internal medicine doctors or family doctors that you might see as an outpatient. And I talk to them, I tell them the story. They come down, usually at least in our hospital, they talk to you. So, you know, that's like you're telling the story the 5th time. So sorry about that again. And then get you into the hospital to do more tests. Sometimes like a stress test where you walk on the treadmill and they get the EKG. Sometimes they'll do an ultrasound of the heart to check for anything going on. And just kind of work on risk stratification, all the things that lead to heart disease, like high blood pressure, working on that, high cholesterol, working on that, stopping smoking, those kinds of things.
That's
so that
all
was really
great.
involved. I don't know if anyone wanted to hear more or less.
No, I think that was perfect because I think sometimes people have the concern of they know what the hospital wait times are. And so
Yeah.
I think sometimes people have a fear that, well, if I'm having a heart attack and I have to wait for 3 hours, when that's not how it works. That's why they triage people. They take a look at what is going on with you when you come in, and they address those things like heart attacks or strokes or anything that's imminent as soon as possible. So it's something important to keep in mind that wait time should not be something that dissuades you from going to the hospital, because if it truly is an emergency, they will see you in that manner, in an emergency manner. Yeah.
I think that's good to point out. We have a similar system for stroke-like symptoms. If you walk in, a doctor will see you within 10 minutes in our stroke zone to get an evaluation. And so sometimes that will push you, you know, straight to some type of imaging to further evaluate. And then sometimes that will push you into another route. But there are a couple pathways of kind of about the 10 minutes mark where they like to see someone. And of course, if you're coming in via 911 or via EMS, in an ambulance, they radio us ahead what they think might be going on. So if they think that you are having a stroke, again, they will bring you right to our stroke zone, and you will be evaluated right away once you come in.
Yeah. Well, and so, and that kind of goes back to why you have to wait. When people come in, there may be other people that have higher acuity that need to be in front of you for good reason. And you would want that also for yourself. So, for example, I have taken someone to the hospital in Santa Fe who had a fall. They had fallen forward. And so they had broken their nose. They needed stitches across their nose. But because it was a Friday night at 10 o'clock, there was already a person who had been in a motor vehicle accident that was in the emergency room that was being attended to, because that was a very urgent emergent situation. There was also a couple of people who were heavily intoxicated and that were needing some supervision. And so we were, what they did with the individual that I was with, they did a scan to make sure that she didn't have any bleeds. And then we waited for a doctor to come and do the stitches in her nose. But it was for good reason. She was not going to die from a broken nose. However, the person that was in the car accident was not doing well. And so they needed to be seen first. So that's why you got to wait. Other things too is that, like Lindsay talks about, staffing is a huge issue, along with they're finding there is an increased demand for emergency and urgent care services due to this proportionate rise in our senior population who have different and more complex needs. So this situation is unfortunately not going to get any better. So it's really important to just keep that in mind, that if you're going to use emergency services or you're going to use urgent care, you may have to wait, and it may have to be for a while. Coming from the Canadian system, we frequently had people waiting more than 18 hours in the emergency room before they were roomed. It was either sitting in a chair or you were in a bed in a hallway. So it's a problem everywhere, unfortunately.
Yeah. And it does have to do, there is some timing, like time of day scenario. We certainly get busier over the course of the day. So for example, I worked a 5 p.m. shift on Monday, and I work in a 25-bed ED, and there was a 30-person wait in the waiting room the entire night. And I was there until 4 a.m. So that's 3 hours after my shift, we're trying to catch up with everybody, trying to get things moving. And that was in a fully staffed scenario. So, it's just a tough time sometimes in the evening. So, urgent care has the benefit of sometimes being able to schedule like an appointment for you. It's also a good time to check if that's going to be the right place for you, because obviously we don't want you to have to waste your time in urgent care if you're then going to have to go sit somewhere else in the emergency department. But occasionally you just have to wait, and it's very unfortunate, but we do want to see you. Please don't leave. We'd like to see you, and we'd like to get you treated, but often there are just too few resources for too many people. So I wrote this kind of slide just so you guys can get an idea. So obviously every place is staffed a little bit differently. So, my staffing, we usually have about 2 doctors on at any given moment. But at night, technically from 1 a.m. to 6 a.m., there's only 1 doctor for 25 beds. That is taken into account that we have fewer people coming in overnight. So we don't usually have that 1 doctor seeing 25 patients. And that's why, on the 5 to 1 shift, I was there very late, trying to help the overnight doctor kind of square everything away. But each doctor is looking at, 10 patients, 12 patients at any given time. So sometimes when you see your labs a little bit earlier than them, like I said, doesn't mean they're trying to ignore you. They're definitely going to get to you. They'll talk to you about the labs and kind of what the next steps are. But occasionally it will be a little bit slower than you just being able to look at that kind of thing. Or sometimes things will get ordered, like I'll see a lab, I'll order something, but then it has to go through our pharmacy, which is actually an excellent thing, right? Because we don't want to accidentally overdose you with something. So the pharmacist checks every single medication that I write. So that's excellent. That's amazing. I mean, that's a wonderful double check. And then the nurse will also double check their medications before they give them to you. But so all of those things take a little bit of time as well. So there's all these like little pieces that also take a little bit of time, kind of moving you along. And then nurse staffing depends on the state. It's kind of a hot topic in Oregon right now because they're actually just reducing the staffing ratios, which is, I think, kind of probably safer on a nurse by nurse basis, but there's also no flexibility at all. So if something very bad happens all of a sudden, or we get a huge influx of people, there's no flexibility in how many people the nurse can see. They can see 4. So if we don't have other people coming in, then that's just where we are, which has its ups and downs, but kind of in short, too few resources for too many people. And you don't want to be that person that gets all the resources right when you come in. That's probably bad. That means something really bad is happening. We don't want you to be in that spot. So
That's the one time that you don't want a ton of attention. It should not, you don't want it to be all about you in the hospital.
oh yeah, I just put this slide in just to, because there's a lot of other stuff going on. Like we're talking about those little pieces, like the medications where the pharmacists check everything. So, I mean, I appreciate that the pharmacist checks everything. Occasionally they find something that I have done wrong or they have a recommendation to change it. But also, I mean, there are just a lot of other things that are going on that are making you wait a little bit. So, we have technicians that do all of the imaging for us. Sometimes we have multiple scanners. Sometimes at night, the ultrasound technician has to be called in. So they're at home, they're not always here, but you need an ultrasound study. Patients have to be moved around within the hospital anyway. So say you do get admitted because you have something that needs to get taken care of, kind of like moving that around. And then, we have the people that are helping us get food so you can have dinner. We have the lab technicians that are running all those machines and keeping them in order downstairs. And then we have a lot of consultants that we wait on. So, if you come in and you have abdominal pain and I find out that you have, so you have gallstones and you have cholecystitis, so an infection of the gallbladder from a gallstone, well, I'm going to call a surgeon. And it might be 3 a.m. So that surgeon's at home. So I'm going to wake him up. I'm going to say, hey, Dr. So-and-so, I have blank person here. They have cholecystitis, which is the infection of the gallbladder. I started them on antibiotics and they'll say, great, I'll send our surgeons have like a PA that comes in to see you to chat about the surgery or the options for surgery or kind of what the next steps might be. But so sometimes they're in the operating room, so I can't talk to them. So I have to wait a little bit of time. So even though I know what's going on, and you might know what's going on, or you already had a good thought about what was going on, sometimes it takes a while to get a hold of these different people that I need to help you. So I find that it's a little bit harder if it's someone ultra specialized. So if I need a neurosurgeon that also works with eyeballs, that's going to take a little bit longer than to just get our regular surgeon because your appendix needs to come out. Oh yeah, so those are consultants, right? That's a good point. Yes. Sometimes people ask me if I'm going to then perform their surgery, which I find very flattering, but no, I can't perform any surgery. I just do this first part in the emergency room. But the urgent care is not going to have these type of specialists on call, whereas the emergency department will have all the different specialists. So surgery is a big one that I think everyone's familiar with. OB-GYN obviously makes sense. I don't deliver babies, I hope, most of the time. Orthopedics, so any kind of bone, fractures, those kinds of things. Cardiology, we talked about kind of that scenario. Neurology or neurosurgery would be for strokes, kind of depends on the kind of stroke. And then my emergency department sees everyone from newborns all the way up into however old you can be. So we have pediatricians, and then we have the internal medicine doctors. So all of those are different training than what I get. And then all of those are people that I will have to call. And sometimes we call them and wake them up in the middle of the night, like we were talking about. And sometimes they're already doing something, so it takes them a little bit longer just to kind of get back to us. But it doesn't mean that they are not available. They are, and they can be really integral to your care in the emergency department, because sometimes they'll make recommendations to change a medication and then follow up, or maybe they'll actually do a surgery, or they'll want to see you in their clinic specifically. So they provide a lot of really important information that I want to provide to you that I just don't know about.
Awesome. And so, so that's emergency care, and now we have urgent care. Urgent care is a little bit different. We talked about who can go to the emergency room. Like we talked about, everyone can go to the emergency room. Who can go to urgent care? Everyone can go to urgent care, but it's going to be a little bit different. Hours, they're generally not open 24 hours a day, but they have longer hours. And it's a very good option for non-emergent situations, and alternative to the emergency room if it's not an emergency, especially when issues occur after hours of your regular doctor's office. Like Dr. Ballard said, some take appointments, which is why calling ahead is really, really important, because you might be able to schedule an appointment versus sitting and waiting in urgent care for 3 hours. You can find your so you can just Google urgent care to find locations and their times, because you don't want to show up and have them be closed. But you also, another reason why you want to call is because you want to check if your insurance is accepted there. Not all urgent cares accept all insurance plans and policies. And some have an upcharge. So the service that you're looking for may be covered by them, but they may have a visit fee that is out of pocket anyways. Or if they are urgent care, they're the only option that you have, short of going to the emergency room, and maybe they don't take your insurance. You can ask them what their standard out of pocket fees are, because they will have a fee schedule that they can just give to you, so that you know upfront what you can pay out of pocket if they're not billing to your insurance. So urgent care issues that can be seen there are common issues like urinary tract infections, allergies, nausea, sore throats, earaches. Urgent care is a really good place to go for earaches, not the emergency room. Some minor injuries, bug bites, and other skin conditions. So say things that you are not able to wait to see your doctor for, but necessarily would not be very good to be seen in the emergency room, like a rash that's really, really bothering you. And also some urgent cares, there are some here in Santa Fe, you can call and check, also provide things like vaccinations, physicals, and as needed rapid tests, such as those for the flu and COVID. So it's always good to call ahead, tell them what is going on with you, see if you can get an appointment, see if they take your insurance, and then decide whether or not urgent care is the best option for you at that point in time. Again, bring the same list that you would bring to the emergency room, which is all of your medications and supplements, your medical conditions, especially the name of your doctor and pharmacy, because they might write follow-up instructions, they might prescribe medications. So you want to make sure that you have that information on hand. Of course, your health insurance, your vaccination cards. If you're getting vaccinated, it makes life so much easier if you bring your vaccination cards, and then you have a running list of your vaccinations and all in one place, not on 10 different cards, which is something that I often see is everyone pulls out. Now we have trading cards of vaccinations because they're not all on one card. Again, you might have to wait. So it's a good idea to bring your charger, and all patients should bring their patients to the urgent care and to emergency department. So it's similar to when you go to the hospital, you're going to check in. Some even offer checking in online now, which is very convenient, because they also may have forms that you can fill in online, which includes like a health profile, signing off on agreements, inputting billing information and insurance information. So that's really handy. I would always look to see if the urgent care has an online portal. Once you're there, you're going to fill out paperwork just like you would at the hospital. You're going to get triaged, then you'll wait. and wait. Eventually you'll get roomed. You'll have your vital signs taken, and then be assessed by a practitioner. In New Mexico, it's important to keep in mind that you might not necessarily be seeing an MD. Nurse practitioners can operate independently in New Mexico and do have prescribing power. So you may see a nurse practitioner here. Dr. Ballard, I'm not sure about your state, about how that works there, who you would be seeing in urgent care.
Same, it can be mixed. If there's a doctor on site, there might also be a PA and a doctor. So the PA could see you and then the doctor would sign off, or there could be NPs as well.
Yeah. Yeah. And so, and you will receive prescriptions, potentially referrals. So, like possibly to an allergist, or they might write your referral to a cardiologist, instructions about follow-up care, like when to see your doctor, making an appointment with your doctor, or you may possibly be sent to the hospital. So urgent care might not be the last stop in this situation. If they feel that they cannot treat what you are experiencing, and it's an emergency situation, they will either call 911 and have an ambulance come and pick you up, or they may have you drive to the hospital, or if hopefully you have someone with you that can drive you to the hospital. We've seen both situations. So, like Dr. Ballard said, it's similar. Staffing is similar to the hospital, to the emergency room. We have our practitioners that might be family medicine, internal medicine, or emergency trained. Then we have our nurse practitioners, physician's assistants. You'll see quite a bit, especially here in New Mexico. They do have to complete 27 months of medical education and 2,000 hours of clinical rotations, and they work under the supervision of an MD. You also have nurses that are assessing patients, administering treatments, dressing wounds. CMAs, so certified medical assistants, will often be the ones who admit you and take your vital signs. And then some urgent care will have X-ray and imaging capacities. So there may be techs, and that's something. So if you have a broken bone, and you feel like you can be seen at urgent care, this is a situation in which I would call ahead, because they may want to do imaging, and that you want to go to an urgent care with imaging capacities. So that's why you want to call ahead. So, or instead of driving yourself to the emergency room, or to going to urgent care, you may want to call 911. And what kind of, you need to weigh what's going on, and kind of think about, is this something that can wait until tomorrow and you can make an appointment at your doctor's office, or are you able of driving yourself, or is there someone that can drive you to an urgent care clinic, or based on the list of everything, is this an urgent situation, and you need to call 911 and go straight to emergency. If if you do need to call 911, you might need to be the adult in the situation to make the call. Sometimes there's a lot of hesitation around calling 911, and oftentimes there will need to be someone who just steps up and makes the call. And so when you call, you need to know several details, which is the location of where you are, which includes your street address, room or apartment number, or where you are in the building, if you're in an office building. Luckily, most of us have phones and we can just pull up our maps and tell me where I am. Some 911 centers, when you call, they are able to locate you, but it's not always reliable, and not everyone has the capacity to do that. So it's really good to know where you're calling from. They will ask you for the phone number that you're calling from, just in case the call gets dropped, you want to make sure that they can call you back, because they will call you back. Of course, the nature of the emergency, kind of just take a pause before you call 911 to get your thoughts in order and what you're going to say, so that you can tell them details like the injury or the symptoms that are being experienced, and anything else that they may need to know. Keep in mind that your call, say there's a car accident, for example, and maybe you've arrived on the scene. Maybe you were sitting in the intersection and you saw the car accident happening in front of you, and you go to call 911. In places like Santa Fe, where we have a very small call center for 911, you may get a busy signal. I have had that happen many times when I've called 911. So just call back, keep calling back, and until you get through in that situation. And that's because I'm sitting at the intersection, the guy across from me is sitting there, we're all sitting there, we're all on our phones calling 911. So they have all these calls coming in at the same time. But it is important to make sure that you do get through. If the call is dropped, or if you call 911 by accident, they will call you back immediately. That's okay. Pick up the phone. A good way to freak out people working at the call center is to not answer the phone or pick up the phone and then hang it up really fast. So you can tell them that it was an accident or that you didn't mean to call, but do make sure that you pick up the phone if they call you back. And so our last little bit is about primary care. So some studies suggest that large proportions of patients, which may be up to 60%, can be managed using lower acuity care services like walk-in clinics, or scheduling regular visits with their primary care providers. So this is when issues are not urgent. Say you have a rash, for example, that's bothering you, but you haven't scratched through to your bones. If you can make an appointment with your primary care provider, that really is the ideal route. One of the reasons why wait times are also so long in emergency rooms and urgent care is because some people are going for non-urgent, non-emergent things. An example of someone that I talked to who saw someone who came into an urgent care setting was he thought that he had lead poisoning. And as it turned out, he had been poked in the hand by a pencil when he was a kid. And the little spot had never gone away from that little spot of where the lead had gone in. And so that's why he went to urgent care. This is not an urgent situation 20 years later, but unfortunately, other people were waiting because he had to be seen. So it's important to keep in mind that when you are making these decisions, your decision not only impacts you, but your surrounding community as well. So making regular appointments with your primary care provider is the most beneficial route for everyone, but it's also more cost effective. And they're better going to be able to address care for your ongoing needs. And I'm sure, Dr. Ballard, you can speak to some of the things that you've seen in the emergency setting that you probably they could have gone to see their doctor for.
Yes, I mean, it certainly happens at a variety of times, and sometimes it's just an inopportune time, like it's something that happens in the evening. But of course, like we said, we're not going to send you away, so we will get to you. But it might take a while, and I think the answer is sometimes very unrewarding in the sense that you might still need to see the regular doctor. So the example I think that is probably the worst one that I see is medication refill. Yeah, because there's actually a lot of, interestingly, I mean, I'm a doctor and I'm fully licensed, but there are a lot of medications I don't refill for a variety of reasons. Either, there's like a substance use protocol, or there's something that like, it's just not a medication that I'm very familiar with, or it's not an emergency just at all. So we'll try to help you out in the way that we can. But, for example, like, there are regular doctors out there that would be probably more than happy to just take a phone call and refill your prescription for you in a timely fashion.
Yeah, and that's why you want to keep your annual visits so that you can get your refills on a regular basis and not have to go wait in the emergency room to have that done. Because also your time is important too. And if you have to go wait in the emergency room for 6 hours so that you can get your thyroid medication refilled, that's not a very good use of your time either. So that's why our primary care providers, we really want to make sure that we're seeing them regularly. not only for those types of things, but because preventative care really is key to avoiding a lot of these urgent care and emergency room visits. They can catch things before they turn into an emergency, which we just don't want to happen.
So I was looking through some of the questions here. One of them is, why does the ED not have eye doctors or dentists on call?
So we do have eye doctors on call. Most places do. Ophthalmologists, so MDs or DOs that are eye doctors. They're like all consultants, like they're not immediately available they're not in the hospital. But they're like available to come in if there's an emergency. Dentist is I think that's an interesting question in terms of the US healthcare system. Dentists are not doctors, and so they're just not looped into hospitals in the same way. So there are things called oromaxillary facial surgeons, and when I mean things, I mean specialists, like real people, humans. And they do have some crossover into dentistry, but mostly they deal with facial traumas or really complex cancer type cases and not just regular dentistry. But no, you will never be able to see a dentist in the hospital reliably. Some hospitals do have some outreach programs, but I've never seen an emergency department that has a dentist. I've seen some really, really big hospital systems that might have dentistry available, especially for kids. But we do have eye doctors, so that's great. But we don't have dentists, and that would be awesome. But I don't think that there's any like emergency department dentist, unfortunately. That room for improvement.
Somebody was asking, they live in a rural remote area, far from EDs or urgent care. And how do they make a choice where to go?
I think it depends on what they're experiencing and like what time of day it is and how far away they are. So one example is I was out in a more rural area out in Santa Fe County here, and I was with someone who was having chest pain. I knew that it was going to take longer for an ambulance to get out to us than it was for us to drive back into town directly to the emergency room. So we made the choice in that situation to get in the car and race into town. But we went straight to the emergency room because it was a chest pain situation. So but it also, for if it's urgent care, if it's like a Friday night at 8 o'clock, I would be probably going to the emergency room, unless the urgent care is open super late. Yeah.
That would also be a good scenario where you call the primary care doctor's office and talk to the on-call triage nurse or doctor and just see what they recommend.
That's a good idea. Somebody was asking, they said the fracture's listed under urgent care, but do they have x-ray facilities?
So some do. So some urgent cares do. That's why I would definitely recommend calling ahead. And maybe Dr. Ballard, you can speak more to the fractures that are appropriate for urgent care versus the emergency room.
Sure. I think it's gonna have to be something kind of on the small side. I would imagine if you can see the bone, you should probably just come to the emergency department. That's probably gonna exceed the care that they're gonna feel comfortable with providing at the urgent care. And any big joint, I would probably recommend just coming to see us. Like if your hip is out, please come to the emergency department. That's a really big joint. And you're probably gonna need to see the orthopedic doctor as well. Shoulders, I think in young people sometimes can sneak by at urgent care, but predominantly will need to see us. So I think you're probably going to be limited to more like wrist and hand type things, or feet, like toe fractures, those kinds of things. I think would probably be fairly safely managed there. But of course, if they don't have an X-ray machine, they're going to be sending you over to see us no matter what. So I think Elais was on the ball with giving him a call to say, is this something that you can do or not?
Yeah. Yeah,
somebody,
we occasionally get calls in home healthcare about going into people's homes to assess for broken bones and set. And that is not something that we do. So yeah, don't call home care.
yeah, when we talk about people with, that'll call me from villages and say, so-and-so's on the floor and they can't get up, can you come over and help? And I say, well, I can come over and call 911, or you can just go ahead and call 911 right now. And I do encourage you, the people that make the calls and come out to your home, they're wonderful people. They're going to assess the situation. They're going to give you the option to go to the hospital or not. It's not a given, but they are so caring and so giving. I've had them actually crawl through the window at one of our members' homes because she was in a diabetic coma. And so they're just as patient and as understanding as can be. And they're going to give you the best evaluation right there at the time to be able to tell you the importance of either going to the emergency department or not. Let's see, do we have any, I don't know if we're not doing medical questions today, but there might be something that, Lindsay, you might have that we can send out that are the symptoms of a heart attack versus a stroke. We did send out a couple of handouts on these doctors and doctor care and which place to go, but there might be something listed there that might help people understand. I know with stroke, it's pretty straightforward. I mean, if they're slurring their words, their faces kind of off kilter.
I mean, it's a tricky question in terms of legal liability, but the larger scenario is that, I mean, kind of what the newest research is suggesting, for at least for heart attacks and things, is that a lot of people present very differently. Like, we used to have this very slim kind of siloed thought where you had chest pain and it was kind of on the left maybe, and it like went to your arm or to your jaw. But they're finding more and more that there are some other symptoms that can be associated with it, like shortness of breath or nausea or vomiting or sweating, or kind of any combination of those things. So I think that we can probably get something off like the American Heart Association, and then there's similar for strokes, to kind of get the best up-to-date kind of options.
Okay, I can dig that out and I can send that out as a handout. I think Elais, you mentioned the fact of sometimes you just have to be the adult in the room. And I've seen that with a couple of people having strokes where they are resisting having any medical intervention at that point. And at that point, you have to be the adult in the room because if I understand, you have a very short window of time to get treatment for stroke.
Yeah. And this is going to sound very morbid, but if you don't call 911 and they die in front of you, you're going to have to call 911 eventually. Like, so do it now while they're still alive and you can do something about it. Don't wait until it's too late, because that's an even worse call.
Okay. That's a good suggestion. Thank you.
I would reiterate the short period of time if you're concerned about stroke-like symptoms, because the time frame is 4 hours. For most most real big life-changing interventions, it is 4 hours. And there's another component that's like maybe up to 24 hours, but it is a very short window. So if you are concerned, please do not wait if you lost your vision entirely in one eyeball, please do not wait 3 days to come to the emergency department, because there's very sadly nothing that can be done at that point.
Yeah, and that the same goes for falls. We see this quite frequently when someone has a fall and they hit their head and they don't get seen right away, or they decide to wait and see. That can evolve into the same life-altering impacts that could be avoided if they just got seen right away. So it is really, really critical that in those situations, call 911, go to the hospital. It is better to be seen and have to wait for a while and eventually be sent away in good health than the alternative.
We've done so much in fall prevention, and that's one of our big key issues, because you're falling, you hit your head and you really don't know that anything's wrong. You cannot ascertain that yourself. You've got to go to the hospital. So please do save us all a whole lot of worry. And we would really appreciate it. So I think we've answered our questions. So there was one about the time in the ED about heart attack, but I think we've already discussed that. So I think we're good there. So I think we're good. If you have any other questions, I can open up if you'd like to. I can ask you to, you can unmute yourself now if you wish. And if you have any other questions, I want to thank Dr. Ballard, my lovely daughter, and Elais for spending a little bit of time with us and giving us some great information.
I have a question. Can you hear me?
Yes,
Okay. Is there some temperature level at which you should make the decision between urgent care or emergency?
I think that's an interesting question. You know, when you're getting into the kind of 103, 104, and obviously anything over 104, that's gonna cause altered mental status, like confusion or kind of, like not responding very well. So I think that would certainly push you towards the emergency department. Technically a fever is 100.4 or anything above. That's a very, I don't know, there's like a very strange thing out there where people think that if they have like 1 degree of the normal, then they have a fever. But if you want to be really technical and medical about it, it's 100.4. But I would say if you're creeping up into the 103s, it might be signs of something more severe. Because I don't really see a lot of 103 fevers, even in kids. Most people are kind of pan out around 101 at most, or like 101.5. So I think it's not a hard and fast rule. This is kind of anecdotal on that front. But the other thing I would caution is that forehead thermometers are very unreliable.
I'm sorry, what is?
A forehead thermometer, where they use the little
okay.
gun thing. Those are terrible. So an oral thermometer is going to be your best bet at home. If you're really brave, a rectal thermometer is the true standard of temperature, but we would understand why you might not go that route.
Are there any other questions?
So
this
yeah.
is not a question, but I just am very appreciative.
Thank you. We are really thrilled to be able to present these topics to you, and our next one will be on Monday, 9/11, which is okay. So Lindsay admitted you to the hospital, and now you're being discharged. And what do you need to know? And I think that is one of the most confusing times in your life. It can be quite overwhelming, and it's great to know what you should know, and also what the hospital and the hospital personnel should be informing you about. So, and how to get home safely. And then the other part of it will be presented by Brad Coe, who is our great Medicare agent, and he will be talking about what happens when you get that medical bill and how to handle that. Yeah, so sign up for that, and we really appreciate everybody coming, and we greatly appreciate both Lindsay and Elais for your time and helping us navigate these interesting times.
Yes.
Thank you all
Great
very
to
much.
speak with everyone.
Thank you.
Thank you. Very good. Thank
Bye.
you.
Bye-bye.
Bye. Thanks, Anne.
Thank you.
I'm going to end the meeting.